So before starting the malignant melanoma, I would like to discuss about the layers of the skin, and especially the epidermis. So could you tell me what are the layers of the skin? I discussed about skin previously in the critical care. So one is epidermis,
Epidermis, dermis, and
dermis,
hypodermis.
and hypodermis. Dermis is divided into
Two parts,
one is papillary, another one is reticular, right?
reticular and
Now come to the
reticular papillary.
epidermis. Today we'll discuss all the malignancies, skin malignancies that will arise from the epidermis. Now come to the what are the layers of the epidermis? Could you tell me, someone, from superficial to deep, what are the layers? One is stratum. Stratum.
Stratum
You will have to
basal.
have a very crystal clear knowledge about the layers of the epidermis. Otherwise, it would be difficult to understand
Basal.
skin malignancies. No, stratum corneum. Corneum is the superficial one.
Yes,
Then
first one.
comes stratum,
Lucidum.
Lucidum. Spinosum.
lucidum,
Granulosum. Spinosum.
then stratum, granulosum,
Granulosum.
then spinosum, and last stratum basally.
Basal.
Okay. So if you think about what are the skin malignancies, I have mentioned already.
Melanoma,
Yes.
Okay. Look about the spinosum. This is the spinosum, and in the layer of the spinosum, a type of cells is very more than other layers, that is the keratinocytes. Keratinocytes. And the malignancy that arises from the keratinocytes, that is called squamous cell carcinoma. So if you are asked from where the squamous cell carcinoma arises, could you tell me? From where? From which layer?
Keratinocytostratum spinosum.
Very good. So squamous cell carcinoma is nothing but the malignant transformation of the keratinocytes, and the cells are arises from the stratum spinosum, right? So now come to the stratum basale. So the malignancy that arises from the stratum basale, that is the basal cell carcinoma. Cell carcinoma. Okay. So one type of cell that is present in very commonly present in the basal stratum basale, that is called melanocytes. Melanocytes. So the malignancy that arises from the melanocytes, that is known as malignant melanoma. So if you have a close look on this written thing, so squamous cell carcinoma arises from the keratinocytes, and malignant transformation of the keratinocytes is called squamous cell carcinoma, and it arises from the stratum spinosum. And two malignancies arises from the stratum basale. Directly one malignancy that is arises from the basal layers or cells of the basale, that is called basal cell carcinoma, and one cell type is more commonly present in the stratum basale, that is called melanocytes, and the malignant transform of the melanocytes is called malignant melanoma. So could you tell me what are the malignancies that develops in the stratum basale? Could you tell me? Okay, so let's divide three malignancies. First, one is malignant melanoma at first, then basal cell carcinoma, then squamous cell carcinoma. So at first, always remember, malignant melanoma is the most deadly. Always remember, it is the most deadly. We'll get few difference in our book, but these are the main thing you'll have to remember regarding the skin malignancies. So malignant melanoma is the most deadly, and it is metastasis easily and grows very rapidly. Mets easily and grows rapidly. And could you tell me from which layer malignant melanoma arises?
Stratum
Basal.
basal.
Stratum
Yes, from the
Melanoma.
melanocytes at stratum basale. Right. This is the most important thing. Okay. Then come to the basal cell carcinoma. Always remember, basal cell carcinoma is a least malignant tumor, least malignant or least invasive tumor of the skin malignancies. Least malignant tumor, skin malignancies. And could you tell me from which layer it arises? Is also stratum
Basalis.
Basal.
basale. Stratum basale. Then come to the squamous cell carcinoma. So squamous cell carcinoma arises from, and this is also aggressive. This is aggressive tumor. But always remember, if you remove early, if you remove this tumor, remove early, the chance of recurrence is less chance of recurrence, less chance of recurrence. And this is very important in case of squamous cell carcinoma. The metastasis is always be with, tell me how squamous cell carcinoma is metastasized? Lymph node metastasis. Are you clear? Are you clear?
Yes.
And basal cell carcinoma is a locally malignant tumor. Locally malignant or locally invasive, locally malignant. And regarding the malignant melanoma, how it is metastasis? Someone, do you have any idea? Lymph nodes, blood vessels. Lymph node and blood vessels. So these are the main thing you will have to remember regarding these tumors. So have a quick recapitulation. So at first we have discussed about the layers that are present in the epidermis. There are 5 layers, and the malignancies that arise from the stratum spinosum, that is called squamous cell carcinoma, and that is the keratinocytes. And from the basal, 2 types of malignancies are arises. One is basal cell carcinoma, and another is melanocyte is more commonly present in this layer, and the malignant transformation of this is called malignant melanoma. So we have discussed about the main difference between the 3 types. One is, this is the most deadly, early and progresses, grows very rapidly, and this is the least malignancy. And squamous cell carcinoma is aggressive, we have discussed, and we have discussed from which layer these are arises. And squamous cell carcinoma metastasis to the lymphatics mainly. Basal cell carcinoma is locally malignant, and malignant melanoma metastasis both lymphatics and blood vessels. Are you clear? Are you clear? Okay. So among
Yes,
these
sir.
3 tumors, I have discussed about malignant melanoma is the deadly tumor, right? So you will have to keep 4 thing in your mind by A, B, C, D. How you will understand that could be a, so what are the thing you look for malignant melanoma? Like this malignant melanoma can develop from a nevus, some kind of nevus, some risk factors, there's so many things. Like a patient has a nevus for a long period of time, suddenly it started to be changing. So what are the things you will have to remember? You will have to look for whether it is a malignant melanoma or not. For your gross idea, at first look for A. A is for asymmetry. So 2 sides of pigmented mole do not match. So if there is any, so let have a look here. So this is a mole. So he said 2 sides of mole won't match. That would be different. So that would be different. That is called asymmetry. Then B is for border irregularity. Border. So you will look whether about the border, how the border is formed, whether it is a regular border or irregular border. So border would be irregular like this way. So C is for, do you have any idea what is C? C is for color. So you'll come to know if this is a, sorry, if this is a malignant melanoma, you'll come to know that some sides of this melanoma is like reddish, some sides of this like blackish. There are so different types of colors will be present in a single mole. So this is for color. And D is for mainly diameter, and the diameter would be more than 6 millimeter, and sometimes this is written this is 7 millimeter in diameter. Then if the nevus or some mole is present by this way and there's a sudden change and the changes are like this way, then you will have to think that is the malignant melanoma. And if we think about the squamous cell carcinoma, I am giving you just a gross idea at first. Then I'll come into our main topic. I am giving you the gross idea about the spin malignancies. So if you think about the squamous cell carcinoma, you will be shown some pictures. So how the malignancies are looking like. I have discussed about 3 malignancies: squamous cell carcinoma, basal cell carcinoma, and malignant melanoma. So could you tell me from which malignant melanoma is arised?
Fine.
Basally.
Basally.
Basally from melanocytes.
Melanocyte. That's why the malignancy that are from the malignant melanoma, that would be the colorful and dark colored, because there will be so much melanin here, dark color. So whenever you are shown a picture that is the blackish or dark color, don't go for any other thing, just directly go for this is nothing but the malignant melanoma. I'll show you in the picture subsequently. Are you getting me, everyone? Are you getting me? So whenever you are showing any picture that is dark colored and hyperpigmented dark color, your diagnosis is nothing but the malignant melanoma. Now come to the squamous cell carcinoma. Squamous carcinoma, especially if there are any ulcers, any mole with ulcers, and especially in the lower lip, that is nothing but squamous cell carcinoma. You'll be sure if the examiner shows you a picture that is that could be also dark colored, that's okay, because these tumors are arises from the keratinocytes, that's okay. But there would be a ulcerous lesion over the mole or something else, or the lesions, and mostly that the picture that would be shown you that involves in the lower lip, that is the squamous cell carcinoma. And what about the basal cell carcinoma? Basal cell carcinoma always be pearly. And if any picture that is shown you mostly in the upper lip, involves in the upper lip. So in the MRCS history, these things are from the practical. These things are not taken from the book. I'm telling you from the practical life and the recurse questions. So any picture that involves in the lower lip and there is a high color and there is a presence of margins inverted and presence of ulcers in the center, that is squamous cell carcinoma. And if pearly, there is the upper lip, there is the basal cell carcinoma. And if there is a malignancy, dark colored, there is the malignant melanoma that could involve throughout the body. Are you clear, everyone?
Yes.
Okay, so I have given you the main concept about those things. Now come to our main book. So could you tell me on what is the page number? In your book.
4.
Sorry.
CC 3 or 4?
Okay.
76, भैया.
So someone read this term for me. Someone read this.
Skin lesion, you are given a pathology report. Report shows epidermis and dermis, where is proliferation of atypical non-pigmented epithelial melanocytes at the junction and invading the dermis up to the deep margin.
Okay. So come to this picture at first. So have a look here. So I told you any picture or any lesions that is the high colored pigmented and margins is irregular and both sides are different color. So this is the melanoma or malignant melanoma. So we have seen the picture. We have seen a picture of malignant melanoma. Now you will be asked one question. So describe three histological features that will indicate poor prognosis. So you'll have to know about the prognosis. So regarding the poor prognosis, you will have to see whether there is any invasion, whether there is any invasion is present or not. So if the invasion is in the deep dermal or the subcuticular, that would present with a poor prognosis. So poor prognosis. So understand, to poor prognosis or of malignant melanoma, we'll have to look for invasion. Then the second point, we'll have to look for any important is the local invasion, basically local or surrounding structures. Surrounding structures means the skin invasion or local invasion. And secondly, you'll have to look for it is also invasion, but it is the lymphatic blood vessels or perineural invasion. So it is basically skin involvement, whether it is the we look for the depth. Basically you look for the depth, whether it has involved the dermal or subcuticular tissue. Then look for the invasion. Then you will have to think whether there is any ulceration is present or not. Ulceration. So if there is any ulceration, always remember, in case of any skin malignancies, is there any ulceration, the prognosis is very, very, very poor. So poor prognosis. So I think it's a recall question. This is a recall question. So I always mention that in recall question, you will get some different words, different wrong information. So I would request you to guide is in your book. So for poor prognosis, just number one would be the depth. Look for the depth, whether it has involved the dermal layer or subcuticular layer. Then second point is the invasion. Then third point is the ulceration. So what are the things you look for to have an idea whether there is a poor prognosis or not? So what are the things? Someone please tell me.
Depth, invasion, and ulceration.
Okay. So someone tell me, what is malignant melanoma? I already told you. What is malignant melanoma?
Malignant transformation of melanocytes which arises from stratum basally.
Okay. So these are the findings of poor prognosis. So if you are asked, so what are the indications of the good prognosis? You found a malignant melanoma. So how would you understand whether what about the prognosis, whether it is good or bad? So how would you understand? I told you about the poor prognosis. So what
Reversal of this.
Yes, reversal of this. So at first the depth would be limited,
Low.
right? Limited depth. There would be no invasion
No ulceration.
of lymphatics, blood vessels,
Blood
perineural,
vessel.
and no ulceration. These are the recall question. I mentioned you won't get these type of questions in any other book. We have corrected those things from the different students, different groups, different MRCS groups. So these are the recall questions. Okay. So if you are asked in your exam why this melanoma is pigmented, someone tell me why this melanoma is pigmented.
Because of melanocytes.
Yes, definitely.
Melanin.
Definitely
Melanin.
because these are originate from melanocytes. These
Right.
malignancies are originated from the melanocytes. Okay. So the another recall question recently came. So why sun exposure is a risk factor for melanoma? Always remember in a sun exposure will get ultraviolet ray. So
Right.
ultraviolet ray directly damage the DNA.
Yeah.
So if any damage to the DNA, body the some protective genes in our body, I don't know that has already been discussed or not. I think we'll get those things later on. What are the genes that are responsible for protection of the DNA? But some protective genes, mention those protected protective genes will correct the DNA. That's okay. But sometimes the DNA won't be corrected and that would be mutation mutation of the DNA. So if there is a mutation of the DNA, that ultimately forms the malignant melanoma. So in your book, if we so I request you to correct those things as I have discussed, and also mention the three things I have already mentioned. These are the recall question. So define the malignant melanoma, neoplasm, melanocytes, mainly as in from the skin. What are the sites? Nasal cavities, retina, castration, mucosa. Why malignant melanoma is pigmented? Because we have already mentioned melanocytes, so it is a pigmented, right? Why sun exposure is a risk factor? High risk radiation and ultraviolet ray can damage the cellular DNA, directly cause the mutation. So always not, it won't be muted. So if there is a damage to the DNA, we will have, or in our body, there's some protective gene, or they will repair the damaged DNA repair gene, those things. So they ultimately repair the DNA, so nothing will happen. But sometimes if there is any mutation to the DNA, that will ultimately lead to the malignant melanoma. Are you clear, everyone?
Yes.
Okay.
Yes.
So you'll be asked some thing in your exam. What are the skin conditions associated with the malignancies? So, sorry, extremely sorry. So what are the skin malignancies that are related, skin conditions that are associated with melanoma? So at first, remember some, just hold for a second. Sorry guys for the interruption. Okay. So if you are asked in your exam, what are the skin conditions associated with malignancy? So you'll have to memorize those things, and these are difficult, but I would request you to memorize like this way. At first, I have mentioned that malignant melanoma would always be mostly arises from the some nevus. So always think about the nevus. So there is three types of nevus. At first, giant congenital nevus. Think about the giant congenital pigmented nevus. Pigmented nevus. Then what are another nevus? Another is
Please, plastic.
dysplastic, and another one is multiple nevi. So at first think about the, or say about the nevus. Then you can also think about that is looking like nevus, that is the xeroderma
Pigmentosa.
pigmentosa. And there is a one that is not colorful, that is the albinism. And another thing you can mention, Frederick Fitzpatrick skin type 1, those things. But I think these things are not commonly asked in your exam, but I request you, if asked, just start with the nevus, then xeroderma pigmentosa, then go for albinism, those. So that would also may ask you what are the risk factors to develop malignant melanoma. So we have already mentioned about how sun exposure is a risk factor. So most important risk factors, always remember risk factors, always remember that is sun exposure, most important risk factors. And mainly that happens in the person who has red hair. So if you can memorize or if you can remember what is the risk factor of the malignant melanoma, I have already mentioned or told about the pathophysiology, how malignant melanoma occurs. So at least mention the most important one, that is the sun exposure, because is the sun exposure is a direct damage to the DNA and ultimately mutation of the DNA and ultimately formation of the malignant melanoma. So another risk factors are patient could be immunocompromised. Patient may have a past history of malignant melanoma. Like patient has patient has red color and patient has a surgery. Patient previously diagnosed as a malignant melanoma, so he is definitely would be susceptible always be development malignant melanoma. So past history of melanoma. And the last one, another one is Hutchinson's melanotic freckles. Some patient in English movies, mostly you will get to know there is so many freckles are present, and those are the mostly known as Hutchinson's melanotic freckles. Are you clear, guys? Are you clear?
Yes, sir.
Yes.
Okay. Okay. So we have discussed about the risk factors and we have discussed about the skin conditions associated with malignancies. So I have mentioned you to look for few things regarding the malignant melanoma, and those are the mnemonics A, B, C, D. But in your real exam, you will be asked a question like this way. Can you describe any system that aid, this is also a recall question, that aid the diagnosis of suspicious skin lesion or macroscopic feature in nevi are suggestive of melanoma. So I have already mentioned, if you can memorize like this way, the way I have mentioned A, B, C, and D, like this way, just tell the examiner like this way. Asymmetry, what are the things? A stands for? A stands for?
Asymmetry.
Okay. B stands for? B stands for? B stands
Border
for?
irregularity.
Border
Yes.
irregularities.
C stands for?
Color.
Hello.
Color. And D stands for?
Diameter.
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 So at least tell by this way, A, B, C, D way. But this is the proper way and this is the nice guideline. So you'll get major criteria, you'll get minor criteria. So always remember, major criteria always contains 2 points. Every single point contains 2 points for each stem, and you will get 5 minor criteria, and for every minor criteria you will get 1 point. So if your score is more than 3, like you get 2 here and you get 1 here, so your total score is 3. Or you get 2 here and you got 2 here, so your score is more than 3. So if your score is 3 or more than 3, then you will have to think about the malignant melanoma. Are you clear? So when you will think a patient does have a nevus and suddenly there is few changes. Suddenly there are few changes I have already mentioned to look for A, B, C, D. Or if you follow the nice guideline, you will get major criteria. So first look for major criteria. So you will have to think about the size, whether the size of the nevus has been recently changed or not. You will ask the patient, does it rapidly grows or something else? Then you will get to look for irregularity of pigmentation. We have to think about the, like here is a pigmented area, here is a hypopigmented area, here is a blackish area, there is a reddish area. So you will have to look about the pigments. And the last one, you will look for the regularity of the outlines of the shape. So we have already mentioned by A, B, C, D. I think it will be easier. So at first, look for the size, whether this has increased in size recently or not. Look for the color and look for the shape, whether there is any regularities or not. So these three things, size, color, and shape. So for every single thing, you will get 2 marks, 2 marks, and 2 points. And what are the minor point? One is diameter. Diameter, and here it is mentioned more than 7. I would request you to memorize like this, more than 7. Though it is written in another surgical book, more than 6. And you look for any inflammation or ulceration, like there is any redness surrounding the lesion, any ulceration or any inflammation, signs of inflammation. So if there is any ulceration, you look for whether there is any bleeding or oozing occurs or not, is occurring or not, or serosanguinary discharge. So look for any bleeding, crust, serosanguinary discharge. And we'll also ask the patient whether there is any itching sensation, and also ask the satellite, look for the satellite lesion. I'll discuss about the satellite lesion later on. Look for any lesions within 2 centimeter of this lesion. So this is the satellite lesion. So these things contains 1. So as a whole, if your score is 3 or more than 3, you will have to think about the malignant melanoma urgently. So this is the NICE guideline. So is there anyone who could mention? What did I say? What are the things you look for? What is the NICE guideline regarding the malignant melanoma? Someone?
Some major and some minor.
Yes, yes. What are the criteria, Bhaiya?
Major like the size of or irregularity
Mhm.
present or not, then the color changes.
Mhm.
And in case of minor, there is diameter is greater than 7 millimeter.
Mhm.
Inflammation or ulceration or any bleeding, crusting or any discharge, itching or tingling sensation or any satellite lesion.
Okay, very good, excellent. Now, the nevus or malignant melanoma or the mole has been excised. Excision done. Then you have supplied a pathology report. Pathology report. So you'll be asked what are the things you will have to look for in the pathology report. So at first you will look for, especially in the pathology report, you will look for the size of the lesion. What are the things you will look for? Pathology lesion. So at the size of the lesion, then you will look for the depth of the lesion, and especially for the malignant melanoma, to look for the depth of the lesion, and this is called Breslow thickness. What is it? Breslow
Breslow thickness.
thickness. I will think about the Breslow thickness because excision of the margin depends on the Breslow thickness. Then look for depth of the lesion. Depth of lesion or invasion. Then you'll have to think about whether there is any ulceration, if there is any ulceration, or there is any invasion to like blood vessel, neural invasion, lymphatics invasion, and ultimately look for the staining of immunohistochemistry. Staining of immunohistochemistry. So these are the things. So you have given a, like this is the lesion. This is the lesion, and this is the skin. So this lesion has been excised, and in the lesion, this is the malignancy. So this lesion has been excised. So it had sent for histopathology examination. So you'll have to think about what are the things you look for in the histopathology. So at first, look about the size, like it is a 1.5 centimeter lesion. That's okay. Then look about the thickness of the tumor, plus mass. Okay. Then look about the depth. How much is had been involved? Depth of this lesion. Whether it is a epidermis, or whether it is involved in the dermis, or is the hypodermis, or other structure. So that is the depth. And another thing, you'll have to look for any ulceration present in here or not. So any lymphatics is involved here, any neural structure is involved here, or any vascular structure is involved here. Look for the surroundings area. and always you'll have to send this for if you send this specimen slide for the immunohistochemistry, look for the specific protein in the immunohistochemistry or specific staining. So these are the things you'll have to look for. Is there anyone who could mention these are the things very important? Alvin bhai, could you mention bhaiya, what are the things you will have to look for in histopathology report?
Size, depth, ulcerations,
Mhm.
and the staining of immunohistochemistry, especially color change,
And
and most important is breast thickness.
that's the thickness. And this is for the excision, right? So now you'll be asked in your exam, what's the difference between the malignant melanoma and squamous cell carcinoma? So I have already mentioned about so many things regarding the malignant melanoma. So I have a look here, and this is the squamous cell carcinoma. So at first, tell me, what is malignant melanoma? Someone tell me, what is malignant melanoma?
Malignant neoplasm, which is only originated from the melanocyte of
Very, very good.
stratum basal.
Yes, arises from the melanocytes, and this is the melanocytes present in which layer here? Stratum basal,
Stratum basal.
and this is the deepest layer of the epidermis. Deepest layer of epidermis, right? And this is the point 2, right? And squamous cell carcinoma arises from which layer here? Which cells?
Keratinocyte of stratum spinosum.
Keratinocytes. So this is called superficial layer. That's why it is superficial to stratum basale. That's why it is called superficial layer of the epidermis. Superficial layer of epidermis. Are you clear? And in case of malignant melanoma, the patient will have to have a now tell me, what is the pathophysiology? How ultraviolet ray causes malignant melanoma? Tell me.
There is damage of DNA, so there is genetic mutation.
Okay. So here it is called the sun exposure. Sun exposure is intermittent. Intermittent. But in case of squamous cell carcinoma, I am telling you always to remember, squamous cell carcinoma is always for the chronic irritation. In any chronic irritation in the body, that the malignancy that would develop, that is the squamous cell carcinoma. You can think about like urinary bladder. Normally transitional cell carcinoma, but cystosoma hematobium causes squamous cell carcinoma. Fistula tract, like is the chronic osteomyelitis, the tract of the fistula. The malignancy suddenly changed the color. So many things have been changed. Surrounding structure of the fistula tract. There is squamous cell carcinoma. Like this is the kidney, this is the ureter, this is stone, or this is the Staghorn calculi, standing for a long period of time, and this is iterating for a long period of time. The malignancy that will develop here, that is the squamous cell carcinoma. Like a patient is having betel nut, and the malignancy that will develop in the mouth, that is the squamous cell carcinoma. So always remember, for developing of squamous cell carcinoma, you will have to have a continuous irritation. So the sun exposure will be continuous or intermittent. Continuous sun exposure, right? And malignant melanoma usually comparatively develops in the younger people, and then this develops in the older people, because for continuous irritation you will have to survive a long period of time. That's why it is commonly develops in the older people, because of for a chronic exposure. Okay, so how this malignant melanoma looks like? Someone tell me how it is looking like. This is looking like.
Dark color.
Yes, darker. That could be irregular. Margin would be I have already mentioned. What about the symmetry? Symmetrical or asymmetrical?
Asymmetrical.
Asymmetrical. That will be darker. Margin will be regular or irregular?
Irregular.
Irregular, right? color will be unicolor or multicolor?
Dark,
Multi,
dark
yes,
color,
darker,
multicolor.
darker, multicolor. And in case of squamous cell carcinoma, I told you about this. This is the red bumpy and scaly, and there might be have a ulceration, and mostly involved when it involves in the face, mostly occurs in which part of face?
Lower
Lower lip, right. In case of metastasis, regarding the malignant melanoma, how it is metastasis? How it is
Both
metastasis?
lymphatic and
lymph node and
blood.
Blood. And squamous cell carcinoma, mainly metastasis.
lymph node, lymphatics.
About the prognosis, what did I say regarding this squamous cell carcinoma? About the prognosis.
Prognosis is good if
Yes,
early diagnosis.
yes, if early diagnosis and excision has been done, definitely prognosis is good. Prognosis is good. And always think about the malignant melanoma, the prognosis would be is poor prognosis. Poor. And I think this is all about malignant melanoma and squamous cell carcinoma. I think now it would be easier for you. Is it difficult for you? Skin malignancy itself is a difficult topic, but I'm trying to make it easier for you. Are you getting me, guys? Please tell me, Dr. Anchal,
Yes.
why didn't you
Yes.
present? Why didn't you present in the last mock in anatomy? I was expecting you, Dr.
Dr.
Rabia and
No,
Dr.
Dr. It was actually Friday. Even last time it was Friday. I cannot miss. I have to be. I am present. I have my earphone on, but I cannot talk because I'm on duty at the time. So it is a little difficult.
Okay.
Night time is fine, but daytime is an issue.
No, I understand, but you do have a very, very less amount of time. That's why I am assuring you
I
to
understand.
have.
Yes. Yes.
Okay, no problem. Okay. Next thing, we have discussed about all about the skin, almost all about the malignant melanoma. Then you will have to think about the operation. So how would you remove the malignant melanoma? So when you want to remove the malignant melanoma, you'll have to keep in mind, you'll have to write malignant melanoma, you'll have to, two things you'll have to keep in mind. One is excision of tumor or lesion, and another one is safety margin. Because to remove this malignant melanoma, you will have to look for the breast flow thickness. How the malignant melanoma is, what about the thickness, like this is a 1 millimeter, 2 millimeter. Depending on this thickness, we'll have to remove the margin. So like at first you found a nevus, and the nevus which has A, B, C, D changes, but it is not malignant melanoma. So the cells, you look for the cells and you found the cells are changing, and this is a atypia. Then simply remove or excise the lesion, and your margin could be 5 millimeter. Like this is the lesion. So if like this is the nevus and you found ABCD changes, so you remove the lesion, and you can also take extra 5 millimeter from here. Like you remove this portion, that is okay, no problem. So the second point is, you found the melanoma, just changes have been started and it is very locally, that is called melanoma, that has not been spreaded, and this is a melanoma in situ. So in this portion, you can take a margin about 1 centimeter, or 5 millimeter to 10 millimeter, or you can say as a whole 1 centimeter. Are you getting me? So if you get melanoma in situ, you can excise the margin up to maximum 1 centimeter. You can also take 5 to 10, whatever you prefer, but if you just say 1 centimeter, that is okay, no problem. Okay. Now, malignant melanoma has been categorized into 4 types depending on the size. One is T1, one is T2, T3, and T4. When the size of the malignant melanoma is less than 1 millimeter, you are allowed to excise 1 centimeter. 1 centimeter. When the size is more than 1 to 2 millimeter, you are allowed to excise 2 centimeter. 2 centimeter. And this is called T2. I'm repeating, I will repeat it again, no problem. When the size is 2 to 4 millimeter, then it is called T3, and you are allowed to remove 2 to 3 centimeter. And when the size is more than 4 millimeter, and that is T4 malignant melanoma, and the maximum you can remove more than 3 centimeter. And this is the Breslow thickness. So this is the Breslow thickness. So what are the thing? Someone tell me. So at first, look for the nevus. If the nevus is having atypia or cells have been started to changing, and you got A, B, C, D changes, just simply excise the tumor, and safety margin is 5 millimeter. If the melanoma, the malignancy has been occurred, but it is in situ, it had not been spreaded, or it has not been involved in other structures, just simply you can remove 1 centimeter or 5 millimeter to 10 millimeter, and this is called 1 centimeter. If the tumor thickness is less than 1 millimeter, you can, the safety margin will have to 1 centimeter. If more than 1 centimeter or up to 1 to 2 millimeter, the safety margin would be 2 centimeter. And if it is 2 to 4 millimeter, the safety margin would be 2 to 3 centimeter. And if it is more than 4 millimeter, the safety margin would be more than 3 centimeter. And this is the largest. The maximum safety margin could be 3 centimeter. Are you clear, guys?
Yes, ma'am.
Yes, doctor.
Yes.
Okay, I think it's not that much difficult. It would be easier for you. Okay, so let's go to the book. We have discussed this thing. We have discussed this thing already. Also the difference. Okay, we have discussed these things previously. How will you biopsy a case of malignant melanoma? Definitely excision and 2 millimeter margin. Okay, just ignore this thing. 2 millimeter margin. If the Breslow thickness is given to you, you won't be asked. Definitely think about, just all of you, I'm telling all of you, you won't be asked about the, could you tell me what is the Breslow thickness? No, you won't be asked like this way. In the MRCS Part B exam, you'll be asked like this way. A nevus has been excised, histopathology report shows patient is having malignant melanoma, and Breslow thickness is 3 millimeter. So what should be the safety margin? Someone tell me, what should be the safety margin? 3 millimeter Breslow thickness.
2 to 3 centimeter.
Very good. 2 to 3 centimeter. Like this way you'll be asked. So they will show you the histopathology report. They will show you the histopathology report, right? They will say the Breslow thickness is 0.76 millimeter. So what should be the safety margin?
1 centimeter.
1 centimeter. They will ask you the thickness is 1.5 millimeter, and during the operation the surgeon has only excised 5 millimeter margin. Is it adequate? Is it adequate?
No.
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 So
No.
what
No.
will you do?
2 to 3.
The next question will ask you, what will you do?
2 centimeter.
Re-excision. I will go for
Re-excision.
re-excision. So they will ask you, what should be the safety margin? What should be the safety margins? Tell me, what should be the safety margin? 1 to
2 to 3
Total
centimeter.
1 to 2 centimeter.
1 to 2
1.5.
centimeter.
So 1 to 2 centimeter, not 2 to
2
3.
centimeter.
Right? Are you getting me? How the question would be asked in your exam? You won't definitely ask about the breast tooth thickness directly. These things are for our MBBS or MRCS Part A exam, but for the MRCS Part B, you will be asked like this way I have mentioned you. So, our question is, which intraoperative investigation will assist you to provide comment on the margin being clean? Whether margin is still malignant, there is malignancy is present or not. So how would you come to know whether this is a free margin or not? All of you know that this is a frozen section biopsy, right? Frozen section biopsy. The next question would be how frozen section biopsy is done. I will discuss those things later on. And another thing, you'll have to write it down. This is a recall question. Another thing is Mohs micrographic surgery. I will discuss those things later on. But still, at first, ask the patient. These are the recall question. I am asking all of you. I know many of you has enrolled in so many batches. I know some candidates who are in another 2 courses, but still I request you. You won't get these questions in other book. Whether you are following me or not, that's okay. That's totally different. But I request you to follow this book because pathology is different. The questions are new here. These are the recall questions, and we worked so hard to make this book in this. And definitely you'll get some printing mistakes, so many things, but this is the latest one. Just believe me. So when they ask you this thing, tell about the frozen section biopsy. So if the examiner asks you, is there anything you'd like to add? Then go for the Mohs micrographic surgery. Mohs micrographic surgery. Are you clear, everyone? In the condition, if
Yes.
the examiner asks you anything else, because you will get this question in MRCS so many times. Is there anything else you would like to add? So our second portion is Mohs micrographic surgery. Okay. The next question, the examiner will ask you, what's the difference between the basal cell carcinoma and squamous cell carcinoma? I want you to answer. What's the difference between the basal cell carcinoma and squamous cell carcinoma? Tell me about from which layer basal cell carcinoma arises? From which layer?
Stratum basal.
Stratum basale. From which layer squamous cell carcinoma arises?
Stratum spinosum.
Spinosum. And this is definitely from keratinocytes. Okay. So tell me about the prognosis. Which is good? Which is good?
Basal cell carcinoma.
Good
Basal cell
prognosis.
carcinoma.
And the bad prognosis regarding comparative to basal cell carcinoma. That's okay, no problem. Which is metastasis more commonly? Which metastasis?
Squamous cell carcinoma.
Almost.
More metastasis. And regarding the basal cell carcinoma, less metastasis, right?
Locally
Locally
invasive.
Less metastasis or locally. That's the appropriate point. Locally invasive. So how it look like? What did I say about the basal cell carcinoma?
Early.
Early.
The only word you will have to remember. They will keep asking you until you say or utter this word, that is the pearly papule. And regarding the squamous cell carcinoma, what did I say? This is the crusted
Mole and ulcers.
Complete
Ulceration.
Full with an ulcer.
ulcerated.
ulcers. There could be some bleeding, and there will be some keratin pulse, so many things. Okay. So these I mentioned already. These are the things. These are the most important things. So have a look in our book. So these are the differences. Differences. You can also add those things. Most common form non-melanotic skin cancers. Right. So have a look here. This is the squamous cell carcinoma, and this is the basal cell carcinoma. So this is basal cell carcinoma, squamous cell carcinoma. Most common type of skin cancer. These are most common. Shiny pearly. So you'll have to utter this word. This is a pearly papule, right? Pearly papule. So umbilicated center. Have a look here. This is the umbilicated center. And telangiectasias. Someone tell me what is telangiectasias? Telangiectasia.
Small blood vessels
More
around the
dilated blood vessels and
dilatation of blood vessels around the tumor.
Yes, these are the basically venules or small veins, and these are the dilated telangiectasias, right? You will get telangiectasias right this way here. So come to squamous cell carcinoma, more common in immunocompromised and transplanted patients. I have mentioned about the what are the malignancies that occurs in the the patient who are immunocompromised in the previous pathology class. Could you tell me what are the malignancies that are developed in the immunocompromised patient? What are the infect?
Kaposi sarcoma,
Is the only thing.
Squamous cell carcinoma of
squamous cell
cervix and
carcinoma,
skin, then Kaposi sarcoma, and then also lymphoma.
Very good, very good. And which part? And squamous cell carcinoma develops in which part of the body?
Cervix and skin.
Very good.
skin.
Okay. So, you'll be asked in your exam, poor prognostic factor in general. Have a look here about the basal thickness. When the basal thickness is more increase, basal thickness is more, then this is the poor prognostic factor. And look for the invasion. If the tumor has been invaded and increase in depth, the prognosis is also poor. Type of the melanoma. I'll come into on details about the types of melanoma. Like have a nodular and amelanotic melanoma. So melanoma are different types. You will get 5 or 6 types of melanoma, like lentigo melanoma. So many types of melanoma, but some melanoma may be melanocytic or colorful, or some melanoma may not be melanocytic. So amelanotic means the melanoma would be colorless. So any type of malignant melanoma, I know all of the doctors do have some confusion regarding this thing. Any type of malignant melanoma could be amelanotic melanoma. Are you getting me, everyone? Are you getting me?
Yes.
So
Yes.
melanoma is different type. You will come to know like lentigo melanoma, spreading melanoma, desmoplastic, acral, or nodular melanoma. That's totally okay. But every single type of malignant melanoma, I have mentioned the 4 or 5 types, 5 types of malignant melanoma, that could be amelanotic melanoma. So when there is any amelanotic melanoma is present, that is a signs of poor prognostic factor. Are you clear? Are you clear? Amelanotic
Yes.
melanoma is poor prognostic. So if there is any ulceration, that is also poor prognostic factor. Any lymphatic or neural invasion, distal metastasis, and patient is male, old age, immunocompromised, pregnant. These are the poor prognostic factor in general. Just add those things: immunocompromised, pregnant. Okay, so are you clear, guys, up to this portion? This station is very important, and if you uh, just keep your attention with me, otherwise it would be a disastrous condition for you, because before exam, you will have to fight with this station or this chapter. It's a very difficult. That's why I am taking a much amount of time to cover this station. Okay. The next question would be excision done. Excision done. Breslow thickness 1.5 millimeter and margin that is taken 0.5 millimeter. So what's your plan? Next plan? What should be your next plan?
Re-excision.
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 Very
Re-excision
good.
One
with
to two
1.5
centimeter.
centimeter,
Up
1.5
to 2.
centimeter
So
margin.
my plan is re-excision. Re-excision and up to. So what about the margin? How?
2
Oh,
centimeter.
yes,
2
very good.
centimeter up to.
20 millimeter or 2 centimeter I will consider. Your answer would be like this way. Okay. So I have mentioned those things about the treatment. Have a look here. So re-excision and think about the 2 centimeter with the margin. Okay. What is the main state treatment of the malignant melanoma? I have mentioned those things. So what are the things? One is excision plus safety margin, right? Safety margin. So suspicious lesion should be undergone excision and biopsy. The lesion should be removed completely as the excision biopsy can make subsequent histopathology assessment is difficult. So you'll have to remove, not part of the lesion. Always remember, don't go for incisional biopsy, just go for the excisional biopsy. Because if you go for the incisional biopsy, if you consider the second operation, then your assessment would be difficult. So go for the excisional biopsy, not the part of the tumor of the lesion. Are you clear? So if the margin is not clear in histopathology, go for the re-excision to clear the margin depending on the Breslow thickness. This is the main step of treatment of malignant melanoma. This is also a recall question. You won't get this thing in any other book. Are you clear, guys? So the thing we have mentioned like this, so you'll have to access, look for the safety margin, and if the safety margin is not adequate, depending on the Breslow thickness, go for the re-excision and consider on the safety margin. Are you clear, guys? Everyone? Okay.
Yes.
Yes.
So you'll be asked in your exam, what are the genes responsible for familial malignant melanoma? So you'll have to, it's a very bad thing, you'll have to memorize so many genes, name of the genes, and without knowing a knowledge or having a knowledge, so you'll have to remember. So in your conventional books or those books are present, there that is written for the familial malignant melanoma, the genes that are responsible CDKN2A, CDK4, MC1R, BRCA2. But if you go for the recent centers, the examiners are not accepting this thing. Examiners are not accepting this thing. So we found a simply single answer. This is the BRAF gene. BRAF gene. Just when they are asking you if there is any gene responsible for familial malignant melanoma, just say about the BRAF gene. And if they ask you, keep continuously asking you, is there any gene responsible for this, any other else, go for this thing. So these things are written in conventional books, but I request you go for this one at first. Are you clear?
Yes.
So the next question, what are the things we will have to consider to ensure a clear margin? Ensure a clear margin perioperatively. So what are the things I have already mentioned? What are the things you'll have to consider whether there is any clear margin or not? This is the what way you will consider to find a clear margin perioperatively.
Frozen section.
Frozen section
Yes,
biopsy.
yes. Why are you so late, guys? Frozen section biopsy. So this is the frozen section biopsy. Second one is, I have already mentioned, Mohs microscopic surgery. surgery, most micrographic surgery. Now, I'll telling you what is the frozen section biopsy and what is the most micrographic surgery. So, both of those two things are adopted perioperatively to see whether the margin is clear or not. So, at first, come for the frozen section biopsy. It's very important and is very commonly asked in the exam. One of my friend have been asked in the Penang, I think, about the how frozen section biopsy is done. Frozen section. So for the frozen section biopsy, at first there is a tissue. There is a metallic disc. At first, this is the let's change the color. So this is the metallic disc. This is the metallic disc. So this is called metallic tissue disc, and above the metallic tissue disc, and this is the tissue is kept. Right? Are you clear? So the next step is this tissue that is kept over the metallic tissue disc that is frozen rapidly, frozen rapidly to -20 to -30 degree Celsius. So this is our first step. At first, the tissue that we have already been excised that would be kept over a metallic tissue disc. So this is a metallic tissue disc, and through the metallic tissue disc that is rapidly frozen into -20 to -30 degree Celsius. Are you clear? Are you clear, guys?
Yes, sir.
Yes.
Okay.
sir.
So then a gel-like media, gel-like media that is called OCT. The abbreviation of the OCT is optimal cutting temperature compound. This gel-like media is added with this thing after frozen it in between the -20 to 30. So the gel-like media or OCT, optimal cutting temperature compound, is added with this frozen thing. So what are the names of the OCT? So one is polyethylene glycol. Another one is, do you have any idea? Polyvinyl alcohol. Polyvinyl, and he just alcohol. My friend only just said about the OCT gel-like media. So the examiner asked my my friend, what are the OCT gel-like media? But he couldn't mention this name, polyethylene glycol and polyvinyl alcohol. Are you clear? Then this thing,
Yes.
like we found this thing, like this is the steel metallic disc. This is the whatever the color. This is the this is the tissue, and tissue has been frozen, and some gel-like media is added with this gel-like media is added, and this thing is removed and taken into a machine that is called cryostat. What is called? Cryostat. Cryostat. This cryostat is used to cut this portion. So our next step is cut with microtome portion of cryostat. Just or simply just say about the cryostat. Are you clear, guys? Are you clear? So
Yes.
after
Yes.
cutting cutting through the cryostat, we found this structure. Just this structure. Then the thing will add some stain with this structure. Those are called hematoxylin and eosin stain is added with
Eosin.
this structure, and that is seen under the light microscope. I don't know what did I draw. This is the light microscope. The light microscope, and that is seen under the light microscope. So these are the steps. You'll have to go look for the frozen section biopsy. So someone tell me, what are the steps? What are the sections? What are the steps of frozen section biopsy? Please don't forget, because you will be asked this thing. It's very favorite, and you'll get these things in many chapters in the pathology stations. Someone tell me, other than Dr. Manarat, other than Dr. Manarat, other than Dr. Manarat.
Okay, so we put the tissue in a metallic tissue disc,
Mhm.
and then it's frozen rapidly to -20 to -30 degree.
Mhm.
Then we add a gel-like media, which is the OCT, which is the optimal cutting temperature compound, which could either be polyethylene glycol or polyvinyl alcohol. And then we remove the tissue and OCT compound, and then we we cut it with the cryostat, the microscope portion of the cryostat, and then we stain it with the HNE and look it under the microscope.
Hematoxylin eosin, right? Hematoxylin eosin, and
Hematoxylin eosin, yes.
we don't remove this OCT. It has been mixed with this thing, and this gel-like media
I
absorb
meant the compound, the
yes, no problem. Now,
OCT and tissue.
yes, now go for the most micrographic surgery. Most microscopic surgery. This is very simple. Like this is a tissue, and this is the tumor. So the thing that is simply this tumor or lesion has been excised here, like the tissue or tumor has been excised here, and some tissue from here are removed with this. Then the light microscope is applied here to see whether there is any malignancy is present in here or not. So when the tumor is excised, a layer of thin tissue is also removed or from the margin along with the tumor. Then they look for the malignancy or any atypical cell is present in the margin, and the way they see the tumorous lesions or malignant cells, and this technique is known as most micrographic surgery, but it is not that much helpful or effective like frozen section biopsy. Are you clear, everyone? So we'll
Yes.
consider two tests. We'll consider two tests during the perioperative assessment, whether the margin is clear or not. One is frozen section biopsy, and another one is most micrographic surgery. I think you are clear right now. So gene responsible for familial malignant melanoma, the other gene that I have mentioned, what are the other genes? CDKN2A. You can write it down. Also have CDK4, MC1R,
BRC.
and BRCA2. These are the other genes, but first mention about the BRAF gene. So post-excision patient develops regional lymphadenopathy. What is the management? So you'll have to consider, you'll have to identify why the lymph node has been enlarged. So look for the FNSC. You can also go for the whole body CT scan, PET CT. You can also have the excisional biopsy. You can go for those things, no problem. Okay. The patient has axillary tissue resected, site resected, but subsequently over 24 hours develops a tense swelling in the arm. Okay. So this is the type of question in your MRCS exam. Even you will get this type of question in your phone call communication. There is a phone call communication, and the station is known as Dama mastectomy. So in case of Dama mastectomy, phone call communication, the patient would, after 1 or 2nd period of mastectomy, the patient is axillary swelling, and there do have some changes in the respective upper limb, and the patient would like to go home against the medical advice. So that station particularly known as the Dama mastectomy. So in this station, I found those station, that station in my real exam, and in that station, my examiner over the telephone asked me why there is a axillary vein thrombosis, and this is the question you can also see here. So look for the stem. The patient has axillary tissue site resected, but subsequently over 24 hours develops tense swelling in the arm. Like a malignant melanoma patient has axillary lymph node swelling, and for the diagnostic purpose, you have resected the axillary lymph node. So the patient develops tense swelling in the arm or the respective site. So your diagnosis is axillary vein thrombosis. Are you clear, Bhaiya? Everyone, are you clear?
Yes.
Okay, so after doing or after resecting of the particular lymph node of the respective site, if the patient is having tense swelling in the corresponding arm or upper limb, your diagnosis is axillary vein thrombosis. It's a clear-cut answer, axillary vein thrombosis. Why this is axillary vein thrombosis, I will come later on. But along this scenario, if the patient is having breathlessness plus breathlessness, then as the axillary vein thrombosis, we'll consider this thrombus has been dislodged and converted into embolus, and when embolus goes into the lung, that will develop pulmonary embolism. Pulmonary embolism, and that's why patient is having breathlessness. Are you clear? Are you clear, everyone?
Yes, ma'am.
So what about the sin? It's a very important thing I'm considering. I will come later on why there is the axillary vein thrombosis, whatever. I'll come those things later on. But at first, think about the scenario. This malignant patient is having lymphadenopathy, and you excise lymph nodes from the axilla. And after excision of the lymph node from the axilla, 2 days later, or 1 day later, patient is having tense swelling in the arm. So what's your diagnosis? That is the axillary vein. Dr. Manara thought is the diagnosis axillary vein thrombosis.
Axillary vein thrombosis.
So if the patient is also complaining dyspnea or breathlessness after having tense swelling or as a removal of the lymph nodes, so what's your next diagnosis? This is the
Pulmonary embolism.
pulmonary embolism. This is the scenario. Are you clear, everyone? So go to the next question.
Yes,
Explain
ma'am.
2 reasons for postoperative axillary vein thrombosis in this setting. So surgery to metastatic melanoma with local tissue injury increase local thrombotic tendency, alter blood flow postoperative. Like this is a axilla, right? This is the person, and malignant melanoma is removed from here. So if the malignant melanoma is removed from here, there will be some inflammatory condition, there will be some edema formation around this thing. So if there is any edema, the normal venous vein will be compressed through the edematous lesion, or if there is any hematoma, the vein will be collapsed, right? So if the vein is collapsed, the alteration of blood flow. So what is Vargo triad? What are the things that are present in the Vargo triad?
Endothelial injury,
So one is endothelial
hypercoagulability,
injury, one is hypercoagulability, and another one is alteration of blood.
alteration of blood
So
flow.
have a look here. If the venous congestion is here, the alteration of blood flow is occurring here, because this hematoma or edematous condition will compress over the veins. This is the first thing. Look about the hypercoagulability. The patient is what is the case of this patient?
Malignant.
So this is a malignant transformation, right? And malignancy itself is a cause of hypercoagulability. So there is another cause, that's why occurs, sir. So you have our last one, endothelial injury. You cut this portion and you resected so many blood vessels, and definitely you have done some endothelial injury. Are you clear? So you have covered every single or every 3 steps of Vargo triad here. Are you clear, everyone? Are you clear?
Yes, ma'am.
Okay, so I think you will consider this is also a recall question. You will consider the answering like this. I have discussed right now. So, what about the treatment of the DVT? What about the treatment of the DVT? I have discussed about the DVT treatment previously. Can you mention what are the treatment of the DVT? Okay, I am telling you in a simplest way. Just always try to cover like this so that you can't forget. So basically, in case of in the treatment of the DVT, I'll discuss those things in the examination in the secrets protocol. But before that, here this is written, that is the prophylaxis of DVT. The thing that is kept in your book, this is the prophylaxis of DVT, how to treat DVT, and also the prophylaxis of DVT. So this is the prophylaxis of DVT. Think about at first that whether it is an acute case or chronic case. So if there is a this is an acute case, if the patient is acute, always consider about the low molecular weight heparin. So what is the name? Fonda
Parinax.
Perinax. And you'll have to keep the patient at least for 6 months. So if it is a acute case, or you can also consider warfarin, and warfarin, that dose of warfarin could be 1 to 10 milligram per day, and you can also consider this for 6 months. But regarding the warfarin, which blood test you look for? This is the
Prothrombin time.
no, there is the INR. Basically, that is also the prothrombin time.
Oh,
INR is
okay.
the just conversion of the prothrombin time, but it's called INR. And INR would be 2 to 3. Are you clear, everyone?
3.
Okay. So think about is the number 2. Think about chronic form, like the clot has been formed, and the age of the clot is less than 14 days. The vein thrombosis or thrombus has been formed, thrombus, and the age of the clot is less than 14 days. Then consider about the catheter directed thrombolysis. Catheter directed thrombolysis. But if the age of the clot is more than 14 days, then consider catheter directed or tissue plasminogen activator. Are you clear up to this portion?
Yes,
Okay.
doctor.
Yes.
Okay. Let's discuss those things again. Now the patient operation has been done, and this patient is highly susceptible for development of the deep vein thrombosis, right? So if the patient is highly susceptible for deep vein thrombosis, we will give some drug so that the patient doesn't get or develop any deep vein thrombosis. That's why the treatment will give the patient, that is called prophylaxis of DVT, right? So the prophylaxis of DVT will think about 2 types of drug. One is low molecular weight heparin, that is called fondaparinux, and that is for 6 months, right? Or another drug that is called warfarin, 1 to 10 milligram per day for the same duration, like 6 months, and INR should be 2 to 3 should be INR. Like this is the prophylaxis. Now the patient has developed deep vein thrombosis, and the age of the deep vein thrombosis is less than 14 days. Then if the age of the deep vein is thrombosis is less than, we'll think about the thrombolysis. So how we could do the thrombolysis? One is we'll give catheter directed we will do the catheter directed thrombolysis directly. Another thing, if the age is more than 14 days, we can give the catheter-directed tissue plasminogen activator, and this contains streptokinase or urokinase. So tissue plasminogen activator, what are the things are used for the tissue plasminogen activator? Streptokinase or urokinase. Are you clear up to this portion?
Yes.
Are you clear,
Yes.
everyone? So we'll have to consider this thing. You will have to consider number 3 when the patient has developed DVT. Okay. Now think about these drugs can be used, and patient is developing DVT, and patient is highly susceptible to DVT again and again, and ultimately DVT dislodges and is stuck in the lungs, and patient is contraindicated to use tissue plasminogen activator. You can catheter-directed thrombolysis, even these drug, and patient is developing DVT and pulmonary embolism again and again. Then we will have to consider superior vena cava filter. Are you clear, everyone? And definitely go for the superior vena cava filter pre-operatively. Pre-operatively, if you think about the operation. So these are the things. These are very properly written in your book. You can have a look here. Acute treatment, perinatal anticoagulant, low molecular heparin, fondaparinux. Maintenance anticoagulant for 6 months, surgical practice. Warfarin to keep 2 to 3, standard dose 1 to 10 milligram per day for 6 months. Catheter-directed thrombolysis, if clot less than 14 days in duration, you can use. Okay. You can omit this thing, no problem. Indication for superior vena cava filter, replacement are failure or contraindication to therapeutic antivirals or for pre-surgical prophylaxis setting, subsequent thrombotic risk factors. Are you clear up to this portion? So have a look here. I think it will be easier for you right now. Everyone, are you clear or is still difficult? I don't know. You are not responding. So try to answer like this, sir.
It's clear.
Okay, that's great. Okay, so what are the things you'll have to keep in mind regarding the Varco triad? Someone tell me what are the things?
Endothelial injury.
Very good. Endothelial injury.
Hypercoagulability.
Hypercoagulability. Very good.
Altered
Okay, that's good. Okay, that's good. Okay, think about. I have mentioned about the management of the pulmonary embolism. Someone tell me what is the management of the pulmonary embolism? Right, at first patient is having breathlessness. So how would you diagnose the patient at first? Clinical feature plus examination. Clinical examination. That's okay, no problem. Then the investigation will look for, what is the name of the investigation?
CTPA.
Yes, CT.
CT pulmonary.
So what is the finding you will have in pulmonary embolism, CTPA? What is the finding? Isn't there anyone who can mention? Filling defect in pulmonary vasculature. So this is the specific finding you'll have to say when the examiner will ask you in the specifically in the pulmonary embolism station. He will show you a CTPA. So whether you can understand or not, just go directly go for the, there is a, I can see here, this is a picture of the CT pulmonary angiogram, and there is a filling defect in the pulmonary vasculature. That's the thing. You don't have to say any other thing. So this is the, so now come into the pulmonary embolism. So pulmonary embolism is divided into how many types? Mainly one is
Massive and non-massive.
massive, non-massive,
Non-massive.
massive,
Moderate.
and another one is massive. So how we divide the pulmonary embolism into massive and non-massive? Only one thing. Someone tell me.
Hemodynamic.
Hemodynamic stability.
Very good. Very good. Depending on hemodynamic dynamic stability. So if the patient is hemodynamically stable, then that is called non-massive pulmonary embolism. So what are the things we'll consider in the non-massive pulmonary embolism for the treatment purpose? Low
Low molecular weight
heparin.
heparin.
Low molecular heparin. But if the patient is massive pulmonary embolism, case of massive pulmonary embolism, then we can consider, what are the things we can consider? One is
Bleeding risk is
that's okay. Low bleeding risk or high bleeding risk. So just as a whole, you can consider thrombolysis or what are the things? Thrombolysis or embolectomy. Catheter directed embolectomy. Embolectomy. Dr. Rabia, are you here? Do you understand?
Yes, sir. Yes.
Okay, no problem. So these are the thing we'll divide the pulmonary embolism. So pulmonary embolism basically is divided into three types: non-massive, non-massive pulmonary embolism, moderate pulmonary embolism, and massive pulmonary embolism. Massive pulmonary embolism is divided into low bleeding risk massive pulmonary embolism, high bleeding risk pulmonary embolism. But as this is a Viva exam, and I think you shouldn't consider those things, or you don't need to say so many things in your exam. Otherwise, it will be difficult to answer. Right. So this is the thing. So risk factors for thrombosis is the Varcourt triad. We have already discussed this. Management of the pulmonary embolism, and patient will always have dyspnea. So diagnosis is CTPA. So what the thing we look for CTPA or the finding of pulmonary embolism cases?
Feeling defect in pulmonary
Vasculature. Very good. Then subcutaneous low molecular weight heparin. Patient is hemoglobin stable, and if hemoglobin unstable, and that will be considered as massive pulmonary embolism, thrombolysis, and embolectomy. Right. So a patient known to have hypothyroidism, one finding, with heart swelling in her right inguinal region, her GP sent her for biopsy, definitely for excisional biopsy. So what are the differentials of heart swelling in her right inguinal region? Someone tell me, what are the differentials of right inguinal lymph node swelling?
Infection in the lower limb.
Lymph node
lymphoma, malignant melanoma.
swelling. Okay. So you can divide those things into two types. At first, think about these are the inguinal lymph node. Basically, these are the inguinal lymph node swelling, right? So what are the things, or which area drains into the inguinal lymph node? Someone tell me. Whole of corresponding lower limb, right? This is the first thing. Whole of the corresponding lower limb. Any other thing? Below the area
Below the pectinate line.
Yes,
Pectinate line, the anal region.
Yes,
and
below the pectinate line.
scrotum, vulva.
Yes, that means the skin below the umbilicus or lower abdominal region, right? And the area below pectinate line, anal canal. This is okay. Or you can, as a whole, you can say perineal skin plus scrotal skin. So these are the areas that drains into the inguinal lymph node. So come for the inguinal lymph node swelling. So inguinal lymph node swelling could be divided into two types. One is infective cause, another one is malignant. So think about the infections and malignance that occurs this region. So look for the infection. Yes, very good. Scrotal abscess, very good. Scrotal abscess, right? Even what about the testicular lymph node? What about the testicular lymph node? If any testicular malignancy, paraortic, right? But if testicular malignancy involves the scrotal skin that may also lead to enlargement of the inguinal lymph node. So, testicular malignancy involves the scrotum, that can also lead to inguinal lymph node. So, what are the malignancies? What did I say? Malignant melanoma occurs in which part of the body? Which part of the body? Skin all over the body. So, any malignancy from the lower limb or malignant melanoma from the lower limb that can involve the inguinal nerve. What are the things? What are the malignancies? Look, at first come to the malignancy. So, this is second. And what are the malignancies? If there any primary malignant tumor that occurs in the lymph node, inguinal lymph node,
Lymphoma.
yes, lymphoma.
Lymphoma.
Yes, any tumor that occurs in the lower limb that also involves, okay, any malignancies that occurs in the genital area or perineal area, like penile tumor. So these are the cause of the inguinal lymph node enlargement. So come about the infection, the turnover side scrotal infection. So any infection that involves in the lower limb, right? That could be cellulitis in lower limb. Any genital ulcer, genital infections, STD. What are the STDs? Lymphogranuloma venereum. What other? Syphilis, chancroid, right? CH and croid. So these are the things basically. Herpes. These are the infections. So to answer this portion, you'll have to think, or you'll have to keep in mind what are the areas that drains into the inguinal lymph node. So considering this thing, you'll have to divide into two parts. One is infective causes, another is the malignancies. So think about the malignancies that involves here, and think about the infections that involves this area. This is the answer. Are you clear? Everyone, are you clear? So if you are clear, then you can have a look here. This is the answer. Infections associated with inguinal lymph nodes and malignancy associated with inguinal lymph nodes. Okay. Results of histopathology revealed malignant melanoma. What are the types of the malignant melanoma? So these are the types. So this is the lentigo melanoma. For lentigo, I am focusing some points. Please try to focus those points as well. So lentigo melanoma mainly occurs in faces of elderly people. So this keyword is faces of elderly people here. Okay. Then superficial spreading melanoma or flat melanoma, you have to remember, grows outwards at first to form the irregular pattern on the skin with an uneven color more than 70%. Just have a look here, no problem. Then the third type is desmoplastic melanoma, and this is the rare malignant melanoma, and that is a non-pigmented lesion on sun-exposed area of the body. So remember, it is a rare malignant melanoma. Acral melanoma, remember, always remember, it's a very important, that involves the palms of hand, soles, feet, and nail beds. So specifically in your exam, you may shown so many pictures which involves the nails, which involves the palms, and these are dark colored. So directly go for the malignant melanoma. So what is the type of this malignant melanoma? Just have a look here. Just tell me which type of malignant melanoma this one. Which type of malignant melanoma this one? Guys, are you? Yes. Guys, are you listening me? I don't know. So this is acral melanoma. So which type of malignancy is this one? Which type of malignancy is this one?
Acral.
Very good. So acral malignancy may develop in the palm of the hand, soles, and nail beds. And nodular melanoma are lumpy and often blue-black in color, may grow faster and spread downwards. Now tell me, which type of malignant melanoma prognosis is poor? Which type of malignant melanoma prognosis is poor?
Superficial study.
Did I say that, Bhaiya?
No.
Poor
Amelantic melanoma.
prognosis.
Melanoma.
Most at first, always first thing comes first. Dr. Badar, first thing is nodular. Nodular type has the poor prognostic factor. The second is amelanotic. Melanotic. So tell me which one is the amelanotic melanoma? Which one is that amelanotic melanoma?
Every type
Yes.
every type can be
Every of
melanotic.
these 5 types of melanoma could be amelanotic melanoma. Right? Are you clear, guys? All of you do have some confusion about the amelanotic melanoma. They are looking for, Bhaiya, you said these are the 5 types of malignant melanoma. So from where the amelanotic melanoma comes from? So remember, every type of this malignant melanoma could be amelanotic melanoma. So have a look here. So these are the picture. So which melanoma shows the worst prognosis? Amelanotic melanoma and definitely nodular type. And specifically during pregnancy, I told you before. So descriptive term for non-pigmented melanoma, any type can be amelanotic. Are you clear, guys? Are you clear?
Yes, sir.
These are the recall
Yes.
question. These are the recall question. I'm requesting it again. 2% of the all melanomas are amelanotic. So 2% could be amelanotic. Malignant cells produce no pigments, poor prognosis due to delayed diagnosis. So diagnosis is poor because maximum condition, they don't seek for any medical attention because there is no pigmentation. That's the while you are diagnosing the patient, the malignancy has already been metastasized. That's why the prognosis is very poor because poor delayed diagnosis. Okay, so the examiner will ask you what is the type of melanoma, what is the epithelial melanoma. So for the epithelial melanoma, always remember the histopathologically, like is the melanoma, melanoma. Histopathologically, melanoma are looking like 2 types. One is these cells are looking like epithelial cells, epithelial cells. Another is these cells are looking like spindle shape, spindle shape. Okay, so this is the spindle shape. This is the spindle shape, and like this is the epithelial cells. So they will ask you about the epithelioid melanoma. Epithelioid melanoma means the malignant melanoma or cells from where the malignant melanoma arises. Those cells are resembles or those cells are looking like epithelial cell. Epithelioid means looking like epithelial cells. So these malignant melanoma are looking like epithelial cells. So what are the findings? You will have to look for. You'll have to look for few things. Melanoma can be categorized into 2 major types. One is epithelioid and another one is spindle shape. Epithelial cells are large and rounded, the way I have described. So epithelial cells would be large and rounded and will be abundant cytoplasm. There will be cytoplasm will be abundant and be eosinophilic. They will take so many colors and the nuclei will be prominent. The nuclei will be prominent, large vacuolar nucleoli. So what did I say? The cells will be rounded and large like epithelial cells, and cells will have more and more eosinophilic cytoplasm, and nuclei will be vesicular and large nucleoli. These are the findings you will have in epithelioid malignant melanoma. Are you clear, guys? Are you clear?
Yes, yes, sir.
I don't know
Yes.
whether you are clear or not. Okay. The next question will be asked in your exam. I already mentioned about the satellite lesion. Satellite. After finishing the class, please someone tell me to upload this ugly looking, ugly handwriting containing hand notes. Okay, so satellite lesions. Satellite lesions is for, just have a look here. This is someone's who is laughing with my handwriting. No, I don't want to have this type of lesion someone. Like this is a hand of someone, and this is the malignancy or malignant melanoma. So if any other melanoma occurs within the 2 centimeter of this primary lesion, and this is called satellite lesion regarding or for this primary lesion. So these are the lesions that developed within 2 centimeter of this primary lesion. These are called satellite lesion. So it is a form of local spread. So write it down in a easiest way. It is a form of local spread of malignant melanoma by 2 ways. By number 1 way is contiguity, and another one is continuity. 2 ways, and leading to pigment spread to surrounding area within 2 centimeters, and these are found within 2 centimeter of primary lesion. So they will ask you how these tumors is forms or spreads by the 2 ways. One is contiguity and another one is continuity. So it's a form of local spread of malignant melanoma by continuity and contiguity, and they are found within 2 centimeters of the primary lesion. Are you clear? And this definitely occurs in case of malignant melanoma. Are you clear, everyone? Or it's difficult?
No, it's clear.
It's clear.
Okay, fine. So I would request you to write the definition here along this one. Okay. So how can you know the phenotype of the tumor? To know the tissue origin, always go for the immunohistochemistry. Always remember, to look for the tissue of origin, always go for the immunohistochemistry. Recent histopathology studies and lymph node metastasis other than immunohistochemistry, and definitely go for the gene, BRAF gene. Nice to know what are the genetic subtypes. Only go for the name of the genes. Only go for the name of the genes. BRAF gene, NRAS, NF1 mutation, and KIT mutation. Just nice to know. Just what are the genetic subtypes of malignant melanoma? BRAF gene mutation, NRAS, NF1, and KIT mutation. Just go for only for the names. Are you clear? Okay, so regarding the scenario of this patient, like I think regarding the scenario of this patient, what are the thing we will like to go for the examination? Where would you examine the lady? Tell me, where would you go for examination? You found the patient's inguinal lymph node enlargement, right? And you think about this is a patient's malignant melanoma. So what are the site or primary site you would like to examine, so or inspect? What are the primary sites?
Lower
Both worldly.
Inguinal
one
lymph
is
node would be lower limb
lower
and
limb.
lower abdomen.
Yes, skin below the
perineal
lower
region.
abdomen, perineal region, and genitalia. And specifically, as this type of malignancy most prominently occurs in malignant melanoma, most prominently occurs in nail beds, I will request you to consider or ask the name of this thing: nail beds and also soles. Are you clear? And this malignancy commonly metastasize, and you'll have to consider about the metastasis. What they can metastasize? One is chest, brain, and abdomen. So you'll have to examine these things. So these are the primary site, and these are the secondary or metastasis sites. Are you clear, everyone?
Yes.
Okay. So
Yes.
though it is not written in this scenario, like if you want, then you can also add the FNAC done, FNAC done of this patient, FNAC done, and blindly write it down blindly. This is a recall question. Blindly, just the pathologist palpate the lymph node, and without seeing the structure or without help, taking any help from the ultrasonogram, they directly go for the FNAC. So the next question will be asked in your exam. FNAC done, why you are not satisfied with this FNAC report? Not satisfactory. Why not satisfactory? Just consider this scenario. Tell me why you are not satisfactory. So tell me about the FNAC and biopsy. What is the main important difference between the FNAC and biopsy? Tell me.
We cannot see the
Tissue structure and invasion.
Yes. Always remember, FNAC means fine needle aspiration and mostly only the cells, cytology. And histopathology or biopsy always contains the tissue background. So in case of FNAC, you can only see the changes in the cytology, in the cells. You can only read the cells. But in the biopsy, you can go for the cells, you can go for the surrounding structures, blood vessels, neural invasions, even capsules, so many things you can consider. So in case of FNAC, the sample is not enough sample, but in case of biopsy, sample would be adequate, right? Adequate sample. Okay. In case of FNAC, are you able to see the tissue background? No tissue background. And even you can go for the main differential points of the malignancy or benign, whether there is any basement membrane involvement or not. So you can go for no information about the basement membrane, but you are able to see the basement membrane or involvement of the basement membrane in biopsy. Are you clear? And definitely here the procedure had been done blindly. Blind procedure because they didn't use any no USG. So that could be a false faulty technique, like the pathologist couldn't reach or couldn't taken the adequate sample from the appropriate lymph node. So if the pathology could take or would take the help with the ultrasonogram, that would be more appropriate or that would be more authentic, right? So as the pathology didn't take any help from the ultrasonogram, so that could be a faulty technique. So in the biopsy, you can directly see the structure, directly see the structure, and you can take this sample from the involved tissue. So this is the most important. So always remember, the main important differentiating point is the cytology, and it has the tissue background. This is the only thing you can mention. No, if you want, you can forget those things, no problem. But this is the main thing. Are you clear, everyone? Are you clear?
Yes.
Okay. So they will ask you, how would you treat the patient? Like for the treating the patient, you'll have to exercise as the patient is malignant melanoma. So what are the treatment option? What did I say? Definitely at first, what is the first step? Excision of malignant melanoma with what?
Safety margin.
Safety margin, definitely safety margin. And if so many lymph nodes are involved, always consider lymph node dissection. Lymph node dissection. If the lymph node is involved, always think for lymph node dissection. Then involves the oncologist or radiologist for radiotherapy. Mainly radiologist. Just ignore the oncologist, radiologist for radiotherapy. These are the things you will have to consider to treat the patient. Okay. So come to this portion. These are the types. I have discussed every single thing. So FNSA was done, but not satisfactory. Why? Not enough sample was taken, no information about the basement membrane, no image guided or faulty technique. Why? So how would you treat this patient? Excision of the primary lesion, safety margin, plus as the lymph node is involved, inguinal lymph node dissection plus radiotherapy. A lesion under the toe nail was found and the decision to amputate the toe and excise the lymph nodes was done. What's the objective? So what's the benefit behind this? Excision of the lymph nodes done, amputation of the done, and patient has been diagnosed as a malignant melanoma in the lower limb. So the patient was diagnosed as a malignant melanoma in the lower limb or in the nail toe. Then the excision was done and lymph node dissection was done. So what's the benefit? So what's the benefit you get from this operation, from this amputation and lymph node dissection? Someone tell me from your basic concept. Is there also a recall question? Someone tell me. I'm covering these things. Someone tell me. You just remove the malignancy. Isn't there anyone who could answer? You just
So that it does not
Real local spread.
yes. At first, you remove the malignancy, and there is no chance for local spread. Local spread. Less chance of
and
local spread.
also recurrence, less
Yes,
chance of
prevents
recurrence.
prevent the recurrence, right? And these are the things. Basically, there are so many things are written here. These are from from some groups they have collected. Prevents recurrence and prevents local spread. Just try to tell at this these two. Then control invasion, proper safety margin. You can also mention those things. No problem. But at least first one and the last one. These are the most important. Are you clear, guys?
Yes,
I don't
yes.
know why it's not finishing. Okay. Post-operative, the wound is red and swollen. That what does that mean? Post-operative, the wound is red and swollen. What does that mean? What happened to this? You operated or you
Post-operative infection.
yes, this is the infection. Swollen and culture was done, revealed diplococci, example of the gram-negative diplococci. So could you tell me what are the gram-negative diplococci and what are the gram-positive diplococci? Tell me what are the gram-negative diplococci?
Neisseria,
Neisseria
gonorrhea
virus.
meningitis.
Okay, negative diplococci. One is Neisseria species and another Moraxella
Marxella cataralis.
cataralis. And the another things, as you can remember, Acinetobacter, Haemophilus, Hemophilus also may cause Brucella may also cause. Okay, but these two are the most important. And gram-positive diplococci. What are the gram-positive diplococci? Streptococci,
Streptococcus pneumoniae.
pneumoniae, and enterococci. You will be definitely asked this thing. Definitely, these are the question directly taken from this exam. So if you get this station in your exam, definitely you will be asked this question. Just like this, post-operative, the wound is red, swollen, culture was done, revealed diplococci. Tell me some about some organism or gram-positive organism who having diplococci. So what are the gram-positive organisms having diplococci? Staphylococcus pneumoniae and Enterococcus.
Enterococcus.
Okay. Next, the patient got toxemia with rapidly spreading infection. Rapidly spreading infection. What does that mean? That is the necrotizing
Fasciitis.
fasciitis. Fasciitis. That is the necrotizing fasciitis. I think that is all about the malignant melanoma. So we have covered so many things. So many things. This is a very big chapter for you. And this is, on the other hand, this is very important. So do you need any break? Or I can continue?
Yes, Bhaiya. 15 minutes for
Bhaiya,
dinner.
15 minutes for dinner and break.
Okay, but not more than 15 minutes because we do have 4 more stations to cover. We just covered only 1 station.
Okay, Bhaiya.
But that one station was equal to the next 4 stations.
Yes, 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 yes.
Lots of information.